the session, particularly given the kind of really interesting range of options. I think the easiest way to think about this one is almost directly following on from some of what Phil and Kate were saying about admissions avoidance and the kind of the next stage of that work. So what we'll be doing is looking at and hopefully being able to get some insight from yourselves about the kind of multi-agency aspect to unnecessary admissions avoidance for autistic children and young people and those with learning disability. But to start with, we'll just have a quick round of introductions. So firstly, I'm Andrew Fellows. I work in the health team at CDC on our LDNA work. I've worked on issues around integration of services for disabled children for many years, going back to the Children and Families Act. And before, I spent a few years working on child protection policy and have come back in December. And it's really interesting to see how much progress has actually been made, particularly in this area from where, you know, when I left the sector in about 2017, the Transforming Care programme was in a very, very different place, particularly for children and young people. And I'll let my colleagues introduce themselves and then we'll go around the room. So first, Miri.
Hello, my name is Miri and I'm the Development Officer and the Health team. So I work on the learning disabilities and autism programs and also on contracts with DBOT and DFE.
And Jamie.
Hi, I'm Jamie. I'm the Senior Programs Officer in the Health team as well for CDC, working on all of the contracts with NHS England with LDNA.
Great. And like weirdly, I can only see my own slides. I can't see anyone on the call. Like Miri, you might have to kind of help put people on the spot, but it'd be really great to get a sense of where people are from, what your role is, and your involvement in unnecessary admissions avoidance policy. So whether that's specific around CETR's involvement in DSRs or kind of just a more general knowledge, it'd be really great to get a sense of where people are coming from.
Don't know if you're nominating, but I'm quite happy to go.
Yeah, I'm not able to nominate because I can't see anyone.
Okay,
so yes, thank you for that.
No problem. I'm Scarlett Millwood, so I work in Phil and Kate's team within the National Children and Young People's team, which is part of the Learning Disability and Autism programme. So I'm a programme manager and I work in the first work stream that Phil introduced, specifically focused on admission avoidance. So I work in relation to dynamic support registers and the guidance that will be coming out shortly, hopefully at some point next year. I also work on the community services development area, so that's the 40 million that's coming down to local areas, focused on focused on autistic children and young people and preventing their admission to hospitals, and some other bits and bobs, but that's me in a nutshell. So lovely to meet you all.
And I'll just go through the list and I'll start nominating people one by one. So Caroline Penfold.
Hi, I'm Caroline Penfold. I'm from the London Borough of Havering. My role is I'm Head of Children and Young Adults Disability Service. Essentially, that means I manage SEND and social care services for children and young people with complex needs.
Thank you. Teresa Deverick.
Hello, hi, I'm from Barnet. I'm the DSCO. I was 25 years a SENCO and assistant head, so just moved into this role. I work in the 0 to 25 disabilities team and sit on complex needs panels, work on the autism pathway, a whole variety of things and early help, etc. So just here out of interest, really.
Thank you. Tracy Fisher.
It's always one, isn't there? Sorry, I'm Tracy Fisher, Children's Complex Care Manager and Designated Clinical Officer for SEND in Portsmouth CCG at the moment. We will be joining Hampshire, Isle of Wight and Southampton ICS probably in July we're looking at now. My role involves everything to do with all children with complex care, so commissioning CHC, so the continuing healthcare for children. I also am part of the commissioning team, so I am involved in the CETR process and also the dynamic support registers, and have regular meetings both with our adult and children's contacts within those teams.
Thank you. Jo Gilliland?
Well done. You looked really worried there. So I'm here in two capacities. I wear two hats. So in my first role, I am the North Eastern Cumbria representative for the National Network of Parent Care Forums. But also I am a strategic workforce development manager for family carers, and I work for the North Cumbria North East ICS. So I'm heavily involved in Autism in Schools project, in the Key Worker project, and also work alongside the Learning Disability and Autism team in our ICS.
Great, thank you. Joanne Kirby?
Hi, I'm Joanne Kirby. I'm the Key Worker project manager for the London region for NHS England.
Thank you. Robert Levy? Oh, you're on mute, Robert.
Thank you for that. Nothing like the iPad, is there? I'm actually from Rochdale. I'll tell you where I'm from to start with. I'm actually of two roles. I'm actually a consultant paediatrician who's the clinical director for our service, but I'm also the designated medical officer for Rochdale CCG. And I've been both involved with the dynamic risk register, but also I've chaired a number of CETR meetings as well.
Thank you. Michelle Dammy Johnson?
Hi, yeah, my name's Michelle. I am a social worker and learning disability nurse. I'm currently the autism coordinator for Thameside Borough. I'm here, because my role now covers autism. Well, how do I put it? So the previous autism strategy focused basically on adult, but the new one which starts next month, the refresh, will include children. So, and as part of that strategy, we are sort of looking at early intervention and ways to prevent hospital admissions and that type of work. Yeah.
Mm-hmm. Thank you. And Jane Taylor?
Oh, hi, sorry about that. I'm Jane Taylor. I'm currently a commissioning manager with Brighton and Hove CCG. I'm the CAMS commissioning manager. I've been there for about 3 months. Previous to that, I was in West Sussex as their commissioning manager, but that was slightly different. It was a joint role between local authority and CCG. And as part of both roles, I've been involved with setting up and running dynamic support registers. I'm also a trained CETR chair. And I've spent an awful lot of time in MDT meetings trying to work out how we get young people, most frequently with a diagnosis of ASC, out of our A&E departments and into a better and safer place.
Great, thanks very much, everyone.
Yeah, fantastic kind of range of experiences and backgrounds, which will be really helpful for this. And the reason is because the focus of the session is kind of fundamentally about helping us actually on a project that's looking at the multi-agency aspects of unnecessary admissions avoidance. So we've been asked by NHS England to do that and to produce guidance and resources that focus particularly on the multi-agency dimension and the role that local authorities, education, voluntary sector partners can play. Now, the NHS England guidance, and we'll look at that in a bit more detail, but it's really clear that these processes that you've just explained how you're involved in them should be multi-agency, and it's really important that they are multi-agency for children and young people. But the guidance doesn't provide a great deal of clarity about practically how that should be done and what some of the role of kind of partner agencies are. So we're looking to develop resources to raise awareness and confidence in local authorities and education providers particularly, and hopefully identify kind of examples and good practice where areas have come together, and to show how that can make a positive impact for the children, young people and their families, but also for services themselves. So I'm not going to labour the slides, because we've had a lot of slides today, and obviously people are coming from a place of knowledge. Just to highlight that, as you're all aware, there's been a sustained period of attention on unnecessary admissions avoidance, going back to the original Winterbourne View Concordat, and that animating principle that the Concordat set out, that people should not live in hospitals for long periods. Hospitals are not homes. I think it's fair to say that in the initial stages of transforming care, while children and young people were part of the framework, the specific needs, challenges, issues that they face, that their families faced, and that professionals working with them face, were not necessarily clearly articulated. And there's been a significant move in the guidance over the last couple of years. But despite that prolonged focus and commitment, we continue to see the same messages in a range of reports and investigations, and including relatively recently, that show that too many children and families are still not receiving the support they want and need in a coordinated way at the right time. Children and young people are still being admitted to inpatient units in response to crisis as provision of last resort, are not able to leave sometimes because alternatives aren't available, and care within inpatient units is inconsistent, and in some places and cases remains totally unacceptable. I just got a couple of slides just to highlight where we are in terms of children and young people, and the comparison to the adult population. It's hard to do this from the national data sets, and I'm sure that you will have kind of far more nuanced data from your individual local systems. But the first point is to highlight how, while there's been some kind of fluctuation, the inpatient population has been relatively stable for under 25s, although the initial estimates could well have been an underestimate. But there has been a significant dip between March and December last year. It's hard to know if that's a result of kind of COVID factors, or if it's the impact of some of the improvement programs. But the overall message over kind of the length of time of the Transforming Care programme has been one of stability or kind of fluctuation, and kind of particularly in that under 18 cohort. The second two slides are just about, I think, what's a really stark and really interesting contrast between the overall adult, or the overall kind of cohort of people who are covered by the Transforming Care programme. That's on the left, and we see learning disability only is the most significant factor, followed by autism only, followed by learning disability and autism. And for under 18s and 18 to 24-year-olds, that is not the case. It's autism only, also autistic children and young people that don't have a learning disability, and that's particularly stark for under 18s. And again, and possibly related to that, the gender profile. So for children and young people 18 to 24, the contrast, or the proportions of girls and young women to boys and young men is radically different from the general population. And it has made me wonder to what extent this is a result of changes over time. I can't map that from the national data, but we know local areas are seeing this shift in terms of the cohort that they're working with. What does it mean for kind of identification and provision, and particularly if these are children and young people who are maybe not the children and young people that people anticipated being part of the Transforming Care programme when it was initially established. The long-term plan, and we've heard about that, has kind of recommitted to the Transforming Care programme and further commitments to reduction to more reductions in inpatient care, and there's a recognition of the multi-agency aspect and a commitment to work with DFE and local authorities to improve awareness and support for children and young people with learning disabilities and autism. And it means, you know, we've got some of the points that we heard about earlier on the slide: the strengthening of care, education and treatment reviews, the children and young people accelerator sites that we've seen in the last year, dynamic support registers, and the commitment to key working and the key working service. So the NICE guidance is really clear that, you know, you need multi-agency provision across the range of services that children and young people need. I'm sure that's, you know, fully familiar with everyone, but we're gonna kind of have a conversation about, like, practically what does that mean when it comes to admissions avoidance. And kind of this is just a slide that shows the mapping of that provision and support from the NICE guidance, from early diagnosis, the role of residential provision, short breaks, an education system that understands behaviour as communication, the role of therapeutic short breaks, the role of CAMS provision in understanding LD and autism. These are all elements of the system that have to be in place. Very quickly, learning from the Accelerator sites. So these were the areas that were provided with funding to look specifically at admissions avoidance within their Transforming Care programme. So some of the messages, which again I'm sure people will be familiar with, but the challenges that came out of that were, and I think this is particularly important, a lack of visibility of children who were autistic but did not have a learning disability, and the need to develop robust dynamic registers to capture that. Phil mentioned the upcoming refresh, and that I think will be a kind of critical issue for that guidance, but also how local areas respond. Too many missed opportunities to respond earlier, and small issues not being addressed. Intervention responding too late to avoid hospital admission, and again reinforced by, you know, thresholds and eligibility criteria and silos. Some services not being available to spot purchase, even if the funding was available. Unclear or inconsistent offer for autistic children and young people and their families, and an overarching finding that there was significant system-wide change that was required across health, education and social care services. But there were solutions and enablers that the Accelerator sites looked at. Co-production was absolutely central to getting this right, working with parents and carers and children and young people. An emphasis on early help that is easily accessible, including physically and geographically accessible, was often more useful for children and young people and their families than referring them to specialist services, which in the report kind of indicates that almost elements of that referral onto more specialist services was part of the process of moving children and young people closer to residential or inpatient services. A clearer focus on system design and relationships between commissioners and providers, and we heard a bit about that in the presentation from the Northwest, and a commitment from senior system leaders across a range of organisations that need to provide this support and to really drive that culture change. So I'm just going to pick out a couple of things from the guidance that, again, stress that multi-agency aspect, and I think that's the framework where we'd like people to think about, well, you know, practically what can or what does that look like. So, you know, care, education, treatment kind of policy guidance is really clear that CETRs should be part of a joined up and consistent approach to building the right support. They should have representation from the range of professionals who work with children and young people and local, but at the same time as kind of saying that should happen, it doesn't really provide specificity or a kind of a clear expectation about what that should look like. So it says local authorities and CCGs have considerable freedom in how they work together to deliver this integrated support, improve children's outcomes, and it references the range of legislation and guidance that provides a basis for doing so without really specifying what it can or should look like. The same for care and care education treatment reviews themselves, and that includes community and inpatient CTRs. There's a strong statement around the purpose. One of the purposes of a CTR is to bring people around the table, to have the contributions from different services to try and identify and address barriers and put solutions in place. And if CTRs are held without relevant professionals, then they're unlikely to lead to the best outcomes for children and young people, and every consideration should be given to ensure attendance. And there's a really long list in the guidance of who potentially could be around the table. But there's not a great deal about what the specific role of multi-agency partners is in a CETR, or how the decision-making process, kind of both within and post a CETR, actually works on a multi-agency basis to put things in place. And there's a real emphasis on the chair, I think, in terms of just trying to make that happen following the meeting. Finally, dynamic support registers. Phil mentioned this. They're there to recognise signs that could lead to crisis and get support in place quickly. Now, the national guidance does say that they should be held by the CCG, but part of a wider support system, and local authorities should, potentially schools, should be able to refer in to the DSR. But we know from our own work that there are massive variations in approaches to and the effectiveness of DSRs. And we know that in many areas, either awareness outside of the health system is extremely low, and they're seen as being a kind of a health-held tool. And if rather than a kind of genuinely multi-agency tool whose kind of purpose is understood by all system partners, but if it's not operating as a multi-agency model, if it's not understanding the kind of whole picture of a child's life, of a family's life, of the kind of the role of different services, then it's highly unlikely that it will build a kind of fundamentally accurate picture of children and young people who are at risk of crisis. And in the national data, you can see that the proportion of children and young people who enter inpatient care without having a CETR is extremely high. So we're expecting greater specificity in some of the guidance, and it'd be great to hear about that. But I'm fairly certain that even within that guidance, there'll be quite a lot for local partners to do to work out the mechanisms by which information is actually shared and decisions are taken. But hopefully there will be a greater degree of clarity about who and how children should make their way onto the DSR. So that's just a kind of really short kind of introduction to what the work we're trying to do is. We've got some surveys out there, we're having local events, but we really just kind of want an opportunity to hear from people about where they are working together across agencies to get this right, what some of the key principles for that are. So kind of over to you really to kind of reflect on your own experiences. And yeah, I will stop sharing so I can see people again, but we will send the survey out after this as well. So yeah, we got a hand up, thank you. And that's from Joe.
Hello. So I'll be your starter for 10. I think going back to the point that I mentioned before about CETRs, we've held several workshops where they've been co-delivered by myself and Nikki Sidrick, and that's to both professionals and parent carers alike. And one thing that really came through from that was that parents aren't given a seat at the table when their young people are being talked about. So it very much happens to them, not with them. And quite often a social worker is going to represent that family and they haven't seen the child for 6 weeks, so they don't know what's happening right now. And I just think, it's really important that the people who know that young person the best are their parents and carers, and they can reflect better, the needs and the wishes of the family, because, when this is happening to families, it is a holistic thing we need to look at. A mental health crisis doesn't just happen to the young person who's in crisis, it happens to the whole family. And families often fall apart at this point because They are facing something that's really frightening and horrible, and it's happening to all of them. So I think my big point is that we should be involving parent carers in every aspect when we're talking about their children and their lives. But also to reflect that we've done some really good work. That sounds like I've blown my own trumpet, but in the North Cumbria and North East ICS, we've done a lot of work about admissions avoidance. That's where the Autism in Schools projects come from. We're heavily involved in the key worker role. We had a programme of work that we rolled out over the pandemic around admissions avoidance, which actually I'm presenting at the next session. So it can be done, and it's not always easy, but once you start doing it, it becomes good practice, and it's just expected that, you know, there are parent carer representatives at the table.
No, thank you, Jo. Really helpful, and we will be following up with you about some of the mechanics of that for sure. Jane.
Hiya. I mean, correct me if I'm wrong, but I don't think you can run a CETR unless you've got the consent from the family and they're part of it. I think if you're trying to do it and you're not doing that, then you're not doing a CETR. You know, how can you answer part of those questions? So, I mean, as a chair, and certainly chairs I've worked with won't start the meeting unless we've got that in place. And the way that when I run them, my first part of the session is I put the family with the experts by experience without any of the other team there, and they get that first shot to talk to the experts and let them really have their story and their background, and then we bring the rest of the team in on the back of that, and that's just the way that I have personally run them, and I've found that's worked well. But you cannot do it. I absolutely completely agree. And you know, anyone who tells you they're doing a CETR without the family present, they're not doing a CETR. So but I suppose now I've got the floor. I mean, my experience when I was in my previous role was a joint commissioning role, and that was really interesting because I had a foot in both camps. So I'd got a foot in social care camp as a commissioner and also in the CCG camp as a commissioner, and I found that was terrifically helpful. It's far more difficult in a single agency role. I'm actually just trying to revamp our DSR in Brighton and Hove because it's a bit limp compared to what I've been working with in West Sussex. But it's so much more helpful if you've got access to both sides of the system. I think it being held purely in health is well, as you say, it's got to be a holistic approach. So just leaving it in a single agency really doesn't help the process along at all, I don't think. So that's certainly been my observation is that kind of joint approach as a real starting point makes a terrific difference.
Okay, I'm just making notes about these comments, and then just see Robert.
Just get my video on. Not that you want to see me, but anyway, there you go. I just want to echo what Jane said. Certainly the CETRs we've been doing, obviously the parents are there and they get first shots. And I actually, interestingly enough, the ones I've been involved with, both as a clinician and as a lead, as a DMO, involve very challenging behaviours which parents are not coping with. So at the point, obviously, of going into tier 4 admission. And they actually, interestingly, they showed a video of the behaviours the child was suffering to start the session off, which was quite compelling to social workers who may not have seen the child for several weeks. Just my experience is the process itself. We actually do have co-production in Rochdale. We're quite keen on it, and so we have representatives from independent representatives with the family as well. The problems I tend to have with the process is not actually the process itself. It's actually the bit after the process. It's actually action plan. The action plan is it's a real struggle. So, for example, if you've got challenging behaviour, we'll talk about early diagnosis. It's often difficult to delineate whether the behaviours have a physical basis, for example, and a number of them I've seen are actually physical. The questions from the psychiatry teams: is this physical or not? And then try and get investigations of children with disability, especially those with non-communication, into our local centres who have expertise is very difficult. So, for example, the two I've been to recently, the behaviours were so aggressive, the children put on risperidone, and one of the reasons we wondered about the CETR leading to admission or trying to stop admission was actually what on earth was going on, and come and get investigations, physical investigations on a ward at the same time. And the psychiatrist was asking for MR scans, for scopes, because they thought it was a physical basis to the screaming episodes the child was having. And then, of course, we have gastrology waiting lists of 2 years here in the Northwest. You've got MR scans having to be done distant from where we are because our local unit doesn't do under sedation. And so that delays the process significantly from a physical health and also from a CAMHS point of view, because CAMHS services sometimes don't always want to engage if they feel there's a physical health component to it. And that's become a real problem within our area, actually. I've got 3 or 4 children at the moment at the point of period admission, or with autism, or with non-communication, or with severe behaviours leading to head banging and bleeding of the nose. And we don't quite know the causes of those behaviours. It's partly due to COVID, as you probably gathered, partly due to the fact they've been out of school, partly because they're not in the right specialist school provision, and there's another problem we have. So the action plan afterwards becomes difficult, both the follow-up in terms of physical health issues, the CAMHS follow-up, because they're waiting sometimes for the physical health issues, which are delayed. And also we've got the problem is the child may not be in the right school. Often we've talked today about they're in specialist schools. Some of my children are in specialist schools, but even the specialist schools aren't specialists enough in children with autism. And I have about 3 children at the moment who are on the verge of admission for those very reasons, that they're not in specialist education and waiting 6 to 12 months for that, as well as the physical investigations, as well as the fact that CAMHS are struggling to monitor with their waiting list as well. So I think the overall process is excellent. It's just, I think the services around us are struggling, in my experience, particularly in the Northwest.
Scarlett.
Yeah, so I just had a bit of a question. Do you think that's because a lot of the focus of the guidance at the moment is solely on health, and that actually thinking about the DSR guidance going forward, that's hopefully going to be published later this year? I know that Department for Health and Social Care are interested in it. I'm not sure about the DFE, but do you think there does need to be more onus on really pushing local systems to work more together and collaboratively, so that actually if DSRs do go into the Mental Health Act, which I think there is talk of happening, should that then, I suppose it won't be in law that it's a dual responsibility, but it could very well be in the guidance that it has to be a dual responsibility. And then thinking of the guidance and going back to what Andrew said earlier, it's that operationalization of it, because guidance can do one thing, it can't tell you how to do, implement it locally. And obviously Joe's team up in the north have been brilliant at developing all sorts of wonderful training to really help local areas and share their best practice. So again, I'm thinking of the national support offer that goes with the guidance, which is still in the co-production phases and engagement phases. What do you think might be really helpful to promote multi-agency working, I suppose, in terms of a sort of a training offer?
I think good practice, if someone's doing something well somewhere and people hear about it and then they think, hang on, that seems to be working really well. And from my work over the past few years up here, excuse me, I'm recovering from COVID, so I've got like a horrible cough. So my experience has been about when we start getting things right, and not saying that we get everything right all of the time, but when things start to slot into place, it's about then sharing that information and talking about how we can adapt it to fit for the local system elsewhere, because obviously we appreciate all systems are different. But when we started this, we were coming from a place where we had a much higher number of young people in Tier 4 beds than anywhere than the national statistics were saying, and we have managed, not with one thing alone, but with many sort of interventions, we have managed to drop that number. So from that regards, it's been successful, but also it's about that early intervention, isn't it? And the earlier we can get in there and the more we can support. So our big thing is support within schools, training in schools. Let's stop it being half an hour in a curriculum. Let's make it absolutely mandatory part of your teacher training, part of your TA training. And once we start to sort of understand that all behaviour is communication effectively, then we can start making inroads into what can we do to support best these young people. And I think it's about normalising it. And at the moment, I think we're stepping back from inclusion, and we're moving back towards a more segregated society, which is absolutely not what was, you know, was the intention. So from my personal opinion, we're in a worse place than we are now than we were 10 years ago. And I think that must stop, because everybody is part of society. Whatever your ability or your disability, you're still part of society. You've got to live in society, and these young people who we are excluding to a degree from society now are going to be the adults who are going to be, you know, they're going to come up behind us, and a lot of them, most of them, are perfectly capable with the right support of giving a really valuable contribution to society. So I think it's about embedding that as just being, this isn't just good practice, this is standard practice.
Absolutely, I couldn't agree more, Jo.
And I just, on the initial point that you made, Scarlett, I think the role of the DFE is potentially really important in that, I think there's one of the issues with the current guidance, as well as some of it not being specific about multi-agency. It is NHS England guidance. Local authorities don't read NHS England guidance. Schools certainly don't read NHS England guidance. And if there's something about linking it to keeping children safe in education, for instance, or kind of those core levers, you know, Ofsted have relaxed elements of their inspection framework when it comes to discipline. But I think it feels, when I read the guidance and look at how it's worked, it feels like the kind of it's NHS England guidance that comes to regional and local LDA teams, who are then told to go and get their partners involved. But I don't know if anyone is telling the partners themselves that they should be they should be involved. And clearly, Jo, that the work in the North East is really good work for showing how an area can do that, and we're really keen to. But if there is the opportunity to get it more nationally embedded in business as usual stuff for schools, I think that is a really important point.
And I think, the SEN review and the care review and the white paper and the schools paper, we're in a really good place to do that.
And I think on a national scale, it is telling, isn't it, that we are still very separate organisations. So we still have the Department for Education, we still have the Department of Health and Social Care, and NHS England is separate to all of that because we're not a government agency. So I suppose it's against a backdrop of where we are nationally, politically, etc. So it's just trying to bring it all together against the ICS, ICB land and footprint, which hopefully at some point will definitely influence where this will get us to.
I'm really sorry to stop this discussion, because I think we could go on for a while talking about this. We have to stop the session because we have a workshop changeover, so the next workshop is starting in 9 minutes. So I've shared in the chat the feedback form, and I'll quickly share it on the screen so you can see the QR code, if you wouldn't mind filling out this feedback form. And I'll pause the recording as well.
But yeah, thank you so much. And